Good morning, everyone. It's so nice to see so many familiar faces. I think some of you have been to previous mini medical schools. And I really have to thank Virginia for coming up with this amazing idea and seeing it through. I think this is the third year, right, that we've had this, and it looks like it's going to go forever. So I'm really grateful to you for doing that. So, one of the issues that comes up a lot with older people is medications. And I think these are my learning objectives for today. I'm going to be talking about some of the key issues in pharmacology for older people. I'm going to be talking about the effects of age on pharmacodynamics and pharmacokinetics, and I'll explain what those mean. We all know adverse drug events are common, and I'll talk about risk factors for those, as well as drug-drug and drug-disease interactions. And finally, sort of the general good principles of prescribing for older people. So you've heard this one many times. Our country and the whole world is aging. We currently have over 40 million people over the age of 65. Right now, it's about 14.5% of the population, but soon, within a few years, to be hitting about 20% of the population. Now, even though this is a pretty small percentage, they use a disproportionate percentage of drugs. So even though it's 14.5% of the population, this small percentage uses between about 1/3 to 40% of all the medications that are prescribed. Over 90% of older people are taking at least one drug. So again, very common, the medication use. And polypharmacy is common. So what is that? Well, this is a CDC slide, and it looks at, this color is one drug, this is two, this is 3 to 4, and this one, the greenish color, is 5 or more. And most people use that as the definition for polypharmacy, using multiple medications. So you can see this is 0 to 11 years, this is, again, childhood, this is young adulthood and middle age, and this is people over the age of 60. You can see this is the group that has multiple medications. So this group of people, almost 40% of them are taking 5 or more medications, a very common problem in older people. So I've told you what it is. Another way to define it is if you're taking enough medications that you can make shapes out of your medications, it's probably polypharmacy at that point. Okay. Now, what are the reasons for polypharmacy? Older people have multiple illnesses. So it's not unusual to see that, right? Where they might have high blood pressure and diabetes and maybe a heart problem. So you can see how those medications can pile up pretty easily. The other thing is multiple doctors and sometimes lack of communication between the doctors. I really encourage patients that all their medications should be at least known to one doctor. That should be their primary care doctor. They might be going to see a lung, a heart, a kidney doctor, but everything needs to be known to one person, because that's the one person who's going to kind of look and see whether sometimes you might be taking 2 medications of the same class. They have different names, you don't even know it, right? So one person monitoring that is a really good idea. Over-the-counter medications is a big issue in this country. People assume because it's over-the-counter, it must be completely safe. And actually, that's not true at all. There are a lot of potential side effects. The other thing is because it's over-the-counter, people don't consider it a medication. So when they're seeing their doctor, they may not even tell them because they figure, oh, it's something I just picked up at Long's. Why do I need to tell them? Well, it could be, again, an interaction with your other medications, or it could be some of the prescription medications are available over the counter at a lower dose. Again, the names might be different. You might be taking the same thing, too much of it. Shared medications is a common problem in elderly patients, actually. And again, it's very well-meaning. So, they're talking to their neighbor, and maybe their neighbor says, hey, I'm having trouble sleeping. And they say, oh, here, why don't you try my sleeping pills? Again, not a good idea, right? Because you have no idea what else they're taking. So we tell people, please don't share your medications, just take what you're given. And then nutraceuticals are very common now. I think it was about 10 years ago or so that they said the amount that Americans spend on herbal and other kind of medications that are non-prescription actually overtook the amount that's spent on prescription medications. So whether we like it or not, whether we know it or not, our patients are taking these. And again, they assume that because they are over-the-counter, because it's plant-based, it must be safe, right? It's just a plant product. Well, I'll give you the example of digitalis. Digitalis is a plant product. It's from the foxglove plant. If you take too much of it, and even in some people, if you even take a little bit of it, it can be very dangerous. So this is the other problem with this is somebody was talking to me before this talk, and it's an unregulated industry. So a lot of claims are made, and even the formulation of it is not regulated. So they may say this medication, this bottle contains 20 milligram tablets of whatever drug it is. When they've actually done studies, they've found it's not 20 milligrams. It might be more, it might be less. It's unregulated. So that's the only worry I have with these types of meds. So what are the consequences of taking too many medications? Well, of course, if you take more medications, the interactions and the side effects are also going to be more common. In geriatrics, there's a particular risk. So these geriatric syndromes are the things we worry about. One is cognitive problems, confusion. Very common side effect of some drugs. You wouldn't even imagine it. Some of the allergy drugs. What does that have to do with the brain, right? You're taking it because you have hives or something like that. They can really cause a lot of confusion in older people, particularly if they already have a brain disease like Alzheimer's disease. Sleeping medications are, again, notorious for that, causing a lot of confusion. Falls and injuries can be very common, and all of us know how devastating that can be, right? That can be life-changing to an older person when they have a fall and a serious injury. Incontinence. The first thing I do, if I have a patient who has a new onset of urinary incontinence, the first thing I do is ask, what new medications are you taking? Because chances are it could be that. And then sometimes it's not a specific symptom, but you just see the sort of dwindling. We call it the dwindles. Not a very scientific term, I know, but that's what happens to some older people. They're just sort of not doing well. And sometimes we stop the medications and they perk up to what they were like a year ago. So it just causes this sort of slow decline in functioning sometimes, and it could be because of medications. Now, compliance is an issue with every age. Actually, older people tend to be a little bit more compliant than younger people, but non-compliance is an issue at any age. And at any age, we have people who either don't take their medications, or I think worse, think that if 1 is good for me, 2 must be better, and 3 must be really fabulous, right? So they take too much of it. So both sides of the issue can be a problem. Definitely, if you have a more complicated regimen, it's associated with poor compliance. I'm telling you myself, if I'm put on a 10-day course of antibiotics, by day 3 or 4, you're usually feeling pretty good. I know it's important to complete that course, and I can tell you honestly, I miss doses. Because by the time you're feeling better, right? So you figure, oh, I'm better, why should I take it? It's really important to take it as prescribed, you know? So I'm guilty of this as well, all of us are. I think it's really important to try and take your medications as prescribed. Cost is a big issue for some of our older patients. Sometimes it's a decision about, do I buy the medications or do I buy food? What would you do, right? So I and most doctors, we are notoriously bad at knowing the cost of medications. I know some, you know, the Alzheimer's disease drugs, I know those really well. So a few drugs that are very common in geriatrics, I know those cost quite well. But for a lot of the other drugs, I don't know. So one thing I always tell patients is, if you find your medication costs are getting really high, and if that's a problem for you, come back to me and tell me about it. Because sometimes you can find alternatives. Generics are definitely cheaper. I always recommend generic, but many drugs are not in generic form yet, right? So that's another issue. Some conditions are asymptomatic. So I'll give you 2 examples of that. One is glaucoma in the eye. You know, it's like high pressure in the eye. And the other one is high blood pressure. Both of them, in mild forms, you don't have any symptoms at all. By the time you get symptoms, it's kind of too late to do anything. The damage has already been done. So a lot of people, unless you educate people really well to say, you don't have any symptoms, I'm giving you a medication that might have side effects, but the reason I'm doing this is to prevent these complications 10, 20 years down the road. Unless you do that, people won't take their medications well. I borrowed this slide from one of my colleagues, Dr. Lubomir, who's very interested in medication use. And I found this really interesting. This was a study. They looked at, this is 100% of medications prescribed. And then the drop-off is about 12% don't even get filled. So you get handed the prescription, but it gets filed away in a drawer or maybe thrown away. Down to another 12% of actually getting taken. And this is the amount that's actually continued. So this is a common problem. And I think it's something that we all need to be aware of it, and physicians really need to monitor the use of medications. One thing that happens sometimes with older patients, so let's say they have high blood pressure, they get put on a medication, and the physician is monitoring the blood pressure, next visit, blood pressure still high. So they add a second medication. Again, a few months go by, now the patient gets into the hospital, it's on their list. They're not taking either one of them at home. That's why the blood pressure has been high, right? Suddenly they're given those medications, they bottom out. So again, it's very important to ask the question, are you taking it? How are you taking it? Bring in your bottle to show me so I can see and monitor that, okay? So some very specific problems related to age. One is poor vision. You've seen those little labels, right? They're tiny. So if somebody has bad vision, they may not be able to read that label correctly. Now, pharmacists can actually make large print labels, but you have to ask for them, okay? So that's another issue. Poor hearing. Did they hear my instructions? Particularly here in Hawaii, and particularly with this generation of elderly patients and our Asian culture, they will smile and nod politely at everything you're telling them. So I always ask, at the end of my whole talk about the medication, I ask, so Mr. Tanaka, what did I say? And they smile and nod still, but they haven't heard a word I've said, right? So I always have a sort of talk back to me. You now explain to me what this medication is for and why you're taking it. And then also giving written instructions is good, because how much do you remember of what happens at the doctor's office, right? You're stressed, you're rushed, the doctor's in and out. You've forgotten half the time what's happened. So giving written instructions is always useful. Memory problems, can they remember to take their medications? Now, the danger, of course, is that people with dementia will forget medications. The even worse danger is they'll forgot they took it and take it over and over and over and end up in the ER because they've overdosed now, accidentally on the medication. So I say when people have memory problems, medications need to be supervised in some format or the other. Arthritis, can they open the bottle? They have these child-proof caps. I remember when my daughter was little, she could get into anything. But people with arthritis may have a hard time twisting that little cap, right? So again, you may have to talk to the pharmacist to say, can you give me an alternative type of bottle? Bottom line is, I think you need to keep drugs away from children, child-proof bottle or not, because they'll find a way to get in. Swallowing problems. Have you seen some of those pills? They're like little horse pills. I have real trouble swallowing. Calcium is notorious for that, right? It's this massive pill. I hate that. And so it kind of then sticks in the back of your throat and stuff. So with older people who have swallowing problems, you have to be careful. Maybe find alternatives. Many medications are found in liquid format. Always check before crushing a medication, because some medications should not be crushed. So that's actually the best person to ask that to is the pharmacist. Like, does it affect it? Because some meds, it's fine. You crush them and put them in applesauce. So much easier for an older person with swallowing problems. But check before you do that. So, as Virginia said, we have our medical students doing a required rotation with us. Most of them are young, healthy people, right? Hardly ever take medications, certainly not on a routine basis. We decided they need to know what it's like to take medications. So again, it was Dr. Lubomir, my colleague, who came up with this really cool tic-tac exercise. So this is what we do. My department buys a lot of tic-tacs of different colors. We're not crazy, we're using it for this exercise. So we have these different colored tic-tacs, and we fill these prescription bottles. We actually had one of the pharmacies donate bottles to us. And they have labels on them to say how to take the medication. So they have to take the orange tic-tac so many times a day, and they have to take the blue one so many times a day. And we've made it a very, not too complicated regimen. And then for 1 week they do this, and they have to fill out these diaries, and they have to bring back the bottles at the end of the week, and we look and see how well did they do. They are always shocked at how badly they do. We are not, they are shocked. It is not easy to remember to take certain medications, especially the multiple times a day medications, right? How many times do you remember that? Even if you have a mediset. So it gives them a little bit of empathy for what it might be like for an older person to take multiple medications. We hope it will make them think twice before they prescribe medications and hopefully simplify the regimens for their patients. So I'll move on to pharmacodynamics. What is this? This is what the drug does to the body, the effect of the drug on the body. At the same blood concentration of any drug, for most drugs, older people tend to be more sensitive to the effect of the drug. So let's say I do a blood level on a 20-year-old and an 80-year-old. They have the exact same blood level. The 20-year-old is doing fine, not confused. The 80-year-old might get confused at that same drug level, okay? So we have to be a little bit cautious, and this is particularly true for things that happen in the brain. So you might think, well, this drug is for heart problems, or this drug is for high blood pressure. It has nothing to do with my brain, but it could have an effect on the brain, whether you know it or not, okay? So there are some changes in the brain, even with normal aging. We see a decrease in neurotransmitters. These are for those of you who came to my memory talk last mini medical school, these are the chemicals that send messages between brain cells. So some of those neurochemicals are actually lower in older people. There's an alteration of the blood-brain barrier. This is the barrier that prevents a lot of drug getting into the brain. I have a very low blood-brain barrier, I think, because when I get given even a tiny amount of narcotics, I get weird. So I'm not old yet. When I get there, I'm going to tell whoever my doctor is, don't give me too many medications, please, because I clearly have I think the first time I took codeine, I had some dental thing, and I slept for 16 hours. My husband couldn't wake me up. He was so worried. So some of us tend to be like that even when we're younger, but most older people tend to be more sensitive to the effects of drugs. And of course, neurologic diseases, stroke, Parkinson's disease, Alzheimer's disease, all of these are much more common with aging, right? So it's something you need to be worried about. Next is pharmacokinetics, and this is what the body does to the drug. And these are the sort of subheadings I'll be going over: absorption, volume of distribution, protein binding, metabolism, and excretion. I'll go through each one in more detail. So what about absorption? Well, most drugs we take by mouth, so it's through the gastrointestinal tract. And most of the time, if you don't have a disease of your gastrointestinal tract, the amount of drug absorbed is pretty good. It may be a little slowed, though. So again, if I have somebody taking a medication for a certain reason, and they say it's not having an effect for 2 hours, and I'm expecting that it'll be within an hour, instead of increasing the dose, the first thing I do is make it a little earlier. That makes more sense, right? Instead of just going into a higher dose and going into that cycle. With the GI tract, a lot depends on what else you take with it. So it's really important, again, to get instructions from the pharmacist about should this be taken on an empty stomach or a full stomach. Antacids are notorious for binding to drugs. So if you take certain medications with an antacid, it's not getting into your body. It's just getting excreted because the antacid is binding to it and it's just pushing it through your GI tract. So a lot of different things matter. Intravenous age has no effect on that. Of course, it's going straight into the vein. But intramuscular drugs, this is, getting a shot, that can be very different in older people. So muscle blood flow is lower, muscle mass tends to be lower with aging. So for example, certain drugs that we give as depot preparations, where you can give a shot and that's good for like the next 2 weeks or 3 weeks, I tend to avoid that kind of drug in the elderly because the absorption is very erratic. You can get highs and lows that you cannot predict, whereas in a younger person, maybe it would be okay. Now, I just want to point out something about the skin and the eye. You think that when you're putting on an ointment, that it's just on the skin, right? Some of them get absorbed completely into your bloodstream. So the one that's notorious for that is actually estrogen cream. For people at menopause, they can use it vaginally on the skin. The blood levels are the same as if you took a pill. So if you're thinking it's just having an effect locally, it's not. Okay, so a lot of drug can get absorbed through the skin. Remember, skin is thinner, right, in older people? So the absorption, again, can be much greater than it's expected. Eye drops. Certain eye drops for glaucoma can actually cause confusion. That's one of the side effects. So that's why, again, you might say, why should I tell my primary doctor about my eye drops? I told my eye doctor is the one who needs to know about that. It can affect the rest of your body as well. So good news and not so good news. Body weight tends to go down with age, after the age of 65. Yay, right? Yay? For some of us. Unfortunately, the bad news is you're not losing fat. What you're actually losing is lean body mass. You're losing water, muscle, and bone. That's why weight goes down. The percentage of body fat continues to go up and up and up. I'm so sorry, Virginia, I always give this bad news. Virginia tells me, stay upbeat. I'm trying. So what does this mean for drugs? What it means is for fat-soluble drugs, which are actually most drugs tend to be fat-soluble drugs. Now you have this large pool of fat just waiting to hold on to the drug. What does that mean? Longer duration of action of the drug. So the fat-soluble drugs in older people tend to have a longer effect. They're not excreted from your body because the fat is kind of holding on to them. Okay? The opposite happens with water-soluble drugs. There's a decrease in total body water. Older people tend to be a little bit dehydrated, even at baseline. What does this mean? Now the bucket is half empty. You throw the same amount of drug into a half-empty bucket, it's more concentrated, right? Very simple. The most notorious water-soluble drug is alcohol. So let's say at 20, you'd have 1 drink or 2 drinks. At 80, you have the same amount of alcohol. Your blood level is going to be higher, and the effects are going to be much higher. So the definition of mild drinking changes with age. And in old age, it's actually no more than 1 drink a day, maybe even half for some tiny people. Okay, so again, it's hard to convince older people of that because they say, I've had 2 drinks a day my whole life. Well, when you're 80, your body is handling it differently, right? So it's really important to cut back. Protein binding. So most drugs tend to be bound to proteins in our blood. And if you have a decrease in protein level, particularly for people who are very malnourished, you can have a higher percentage of the unbound drug in your bloodstream. What does this mean? The unbound drug is the active drug. So our blood levels, I don't know if any of you have medications that you take where your doctor actually monitors drug levels. There are certain drugs that we do that for. The drug level might look like it's in the right range. But because you have lower protein binding, there's more free drug, you have more toxicity, because the free drug is the active drug. So I always tell my students and my fellows this, don't treat the number, treat the patient. So let's say for a certain drug, a level of 10 is considered what you want to aim for. You reach that level of 10, and then they're having side effects. Don't say, I'm going to leave them at that level of 10. Maybe you need to cut back a little bit because now they have more free drug. So the level is kind of misleading in older people. Okay, so again, treat the patient, not the number. What about metabolism? This is when the body breaks down the drug, and this usually happens in the liver. And there are some changes just with normal aging in the liver. There's a decrease in liver blood flow, size, and function. It's slight in the absence of disease, but it is there. And so some drugs may just take longer to metabolize. So you just have to be a little bit aware of that and maybe give it at less intervals or maybe a lower dose. Now, certain other conditions, not liver disease, but things like congestive heart failure can have effect on liver function as well. So you have to be careful with those patients. Most of the excretion, getting rid of a drug from the body happens from the kidney. And again, this is actually more predictable than liver. Most older people have some decline in kidney function, which is significant, to the point where it can affect the excretion of their drugs. So what happens with that? There's more drug accumulated and more toxicity with these drugs. Now I want to introduce this term half-life. This is defined as the time for a drug to drop to half its level. So I can show you better in the next diagram. On this axis, I've got the percentage of a drug. So this is the concentration, okay? So at peak, you're at 100%, correct? This period of time, this one half-life, is the time it takes to get from 100% to 50%. So for half the drug to leave the body, okay? This next one is for another half. So it's now going from 50 to 25. Does that make sense? So each half-life, you're going to half the level of the previous one. Now, for a drug to get out of your body completely, it takes about 5 half-lives, about that much. So I've given you an example of a drug called Valium. I don't know if any of you have heard of that. Valium or diazepam. It's a very common sleeping medication, very popular. We hate it in geriatrics. We hate this medication. In young adults, the half-life is 24 hours. In old adults, it's about 100 hours, 4 times as much. Okay? 100 hours, what is that? About 4 days? 4 days times 5 half-lives. We're talking about 20 days to get rid of this drug from your body. That's 3 weeks. So somebody might be taking the drug and they have maybe some side effects. They stop taking the drug. A week later, guess what? They're still taking it. It's in their system. A week later, it's still in their system. So we don't like this drug because it has such a long half-life. Once you take it, it takes a very, very long time to get it out of your system. So in general, we prefer shorter half-life drugs in older people. The converse is true as well. To get to what we call steady state levels, when you first start a drug, it won't have an immediate effect, right? It'll take a little bit of while to get to it. So you need to take a few doses before, and you're kind of gradually going up. So this is, in red, I've got a young person, and in green, I've got an older person, okay? So, as you take it, level goes up, goes down a little bit, goes up with the next dose, with the next dose, with the next dose. It takes a little while to build up to what we call steady state. And this is steady state, it's kind of sort of within the same range. Slower in an older person. So the converse is true. Yes, it takes longer to get rid of a drug, but don't give up too soon. So maybe you've given a drug for a couple of days and you say, it's not working. Give it a chance. Maybe it'll work. You haven't reached that steady state for an older person yet. So then what is successful drug therapy? It's the right drug at the right dose, for the right condition and the right patient. So a lot to think about, right? And failure in any of these can lead to what we call adverse drug events. Unfortunately, these are responsible for 700,000 ER visits every year and for over 100,000 hospitalizations every year. So we can do a lot of harm with medications as well, although of course they do a lot of good. $3.5 billion a year spent just on adverse drug effects every year. And unfortunately, many of these are actually preventable. I think better education and better monitoring would prevent a lot of these. And who's the most vulnerable? Of course, our elderly, frail patients. So there are some known risk factors. Advanced age, the older you are, the more likely you are to have a bad effect from a drug. Higher number of medications. We talked about the polypharmacy issue. Obviously, the more you take, the more likely that you'll have an adverse reaction as well, right? And this includes the over-the-counter medications. If you've had a prior adverse drug event, chances are high that you might have the same thing again with the same class of drugs. Alcohol, particularly for those adverse effects on the brain, alcohol is not a good combination with many of these drugs. Low body weight. Some of our Asian patients here, especially the women, they're 90 pounds. That's their baseline. Obviously, they're going to be more vulnerable, right? So we have to monitor the dose and watch it. And then anyone who has poor kidney or liver function, that can be an issue as well. So I'm going to describe this prescribing cascade. Unfortunately, that happens more often than we like. So let's say somebody starts drug 1, okay? Now you have an adverse drug effect. This is misinterpreted as a new problem. So the patient now has a new problem, right? What happens? Drug 2 now gets added. That also has a problem. Again, misinterpreted. Drug 3 gets added. You see how polypharmacy can happen really easily, right? So and that leads to the cycle of more and more and more drugs. My general rule is, and of course, as with every rule, you have to break it occasionally. But in general, I don't treat the side effect of a drug with another drug. What do you think about maybe removing this drug or cutting the dose of this drug first before adding drug 2, right, or drug 3? So that's something that we want to really be careful about, not sort of this cascade of constantly adding a new drug, interpreting it as a new problem. Maybe it's a side effect of the previous. So drug-drug interactions, two drugs kind of competing with each other is very common, again, more common with higher number of medications prescribed. I really rely heavily on my pharmacists for this. In fact, if I'm not sure, I call them up because they have these fabulous computer programs right now. So they can just run the whole list through the computer and it'll give you the possible side effects or the possible interactions between the two. So I just give them a call and say, can you run this list through, especially if it's somebody who has more than a couple of medications. Drugs can interfere with the absorption of each other. So certain drugs, the blood thinner Coumadin, I don't know if any of you have heard of that or have had people in your family on that. That is notorious for having interactions with not only with other drugs, but even with food. If you have a diet that's skewed in a certain way, it can increase or decrease the level of the drug. It's a very, very difficult drug to take for that reason. So these drug interactions can either exaggerate the effect or actually can diminish the effect. So some drugs, if you take them together, you're not getting one of them because one is canceling out the other. So both sides, it can happen. And then herbal and over-the-counter medications are also really bad. There have been some cases of certain herbal medications interfering with anesthesia, for example, and having some very serious complications. So anesthesiologists now, I think, are becoming much better about asking about those. I think the first few times it happened, they had no idea because the patients wouldn't report it as a medication. They thought it's just an herb. It's harmless. Well, there happened to be some side effects with the anesthesia. So again, it's very important to tell everything you know. Drug-disease interactions. Obesity, of course, can change the volume of distribution, right? Because now there's even more fat. Dementia changes sensitivity to certain medications, or can even have paradoxical reactions. So again, some of the medications that we use for sleep, they're tranquilizers. You figure, okay, they're going to make the person sedated. In a person with Alzheimer's disease, you can have the opposite reaction and they can actually become really agitated. So it's something that you have to be really careful about, again, with diseases. Liver disease and kidney disease, we've already talked about a bit. So what are some of the general rules? My first rule is start low and go slow. I usually start out with about a quarter to occasionally half of the recommended adult dose for older people. If they're really tiny, maybe even lower than that. Once you've given it and the side effect happens, it's very hard to take it away. You can always increase the dose, right? So I'd much rather go slowly and increase it gradually and see what happens. As with everything, always assess risk and benefit. There's literally no drug known to mankind that doesn't have some risk. Every single thing has some risk. So you always have to kind of judge, is it worth it or is it not worth it? Don't quit too soon. Be patient. Everything in geriatrics needs a lot of patience. You have to kind of wait, right, and see. Monitor very closely for side effects. So usually if I start a new medication, if I don't have a reliable caregiver, I will actually call in a week to say, hey, you've been taking it for a week now, any problems? Sometimes they won't even know it's a side effect, but their mom's been acting a little weird recently. Well, maybe it was a side effect of the medication, right? I always avoid starting 2 drugs at the same time, if possible. Sometimes in the hospital when people are really sick, that's impossible. But I try and avoid it because then if you have a side effect, you don't know which one caused it. So I'd rather introduce one at a time if I can. And then this is my own private roller coaster rule. My husband and I love roller coasters. We've always loved them. My daughter now is also becoming a roller coaster fiend, so it seems to be a familial thing. Maybe it's genetic, I don't know. By the way, this is the type I really love, the kind that goes kind of crazy. Maybe that accounts for my thin blood-brain barrier, I'm not sure. Anyway, so many years ago, my husband and I decided we won't ever ride a roller coaster in the first year that it comes out. Because that's when all the problems happen, right? That's when you see this, people were stuck upside down for 2 hours because they couldn't be rescued. And so we've broken that rule, but we made that rule that we will not ride the roller coaster the first year. We'll wait, be patient, and then ride it later. Well, with medications in elderly people, that's my rule too. I usually don't jump on brand new drugs. Again, with a few exceptions. When the first Alzheimer drug came out, that was the only thing I had. Of course, I had to try it. But most of the time, a new drug for high blood pressure, new drug for diabetes, I wait and see. And sometimes they get recalled, or a lot of things come out about that drug. I don't want to test it on my most vulnerable patients, right? So that's my roller coaster rule. Wait and be patient. So for appropriate medication use, we have to always ask ourselves, first, is it necessary? What are the goals and the endpoints? What are you aiming for? With high blood pressure, with a certain age group, maybe your goal isn't, a systolic blood pressure of 120. Maybe it's a little bit higher than that. So I think that's something that the physician has to always think about. Do the benefits outweigh the risk? Always think that. If it doesn't, don't give it, right? You don't want something that's going to cause more harm than good. Are you treating the effects of another drug? I always ask myself that question. I don't want to get into that cycle, of chasing one drug with a second drug and a third and a fourth. Could one drug be used for 2 conditions? Sometimes yes. Maybe it's better to use that. And then are there any possible interactions? So some good habits is good education for your patients and their caregivers. Does the patient know what they're taking things for? I've had patients show up in the ER because they were popping their heart pills because they thought it was for anxiety. So every time they got anxious, they'd pop a pill, and they ended up with an overdose in the ER. They didn't know what they were taking or why they were taking it. That's crazy, right? They really need to be educated. How do you take it? Are there possible adverse events you want to watch out for? So not just verbal instructions, but written instructions are really important. Simplifying the medication regimen is important. As I showed with that tic-tac exercise, young, healthy people had a very hard time following not that complicated a medication regimen, right? So it's important that we make it as simple as possible. Avoiding certain high-risk medications. I think one of the handouts I provided is from the American Geriatric Society. There are certain medication classes that are actually notorious for having major side effects in older people. We try to look for alternatives. And then I have this very sophisticated method of monitoring medications in my patients. I call it the brown bag method. Tell them just throw everything into a bag and bring it in at every single visit. This includes ointments, eye drops, over-the-counter, herbal supplements, vitamins, whatever you're taking. I've discovered some really scary things. I had one patient bring me this vitamin that was recommended by a friend. It was called Ultra Mega Vitamins. So she figured, wow, that sounds really good. It had toxic doses of certain vitamins that are fat soluble. You can't take too much of them. I didn't find out until she actually brought it in, because she kept telling me, I'm taking this vitamin, I'm taking this vitamin. I said, I really need to see it, you know? Finally, when she brought it in, I nixed that one pretty quickly. That's why actually for geriatrics, a home visit can be very, very useful. I've gone on home visits. I'm very nosy on home visits. I go into the kitchen where they store their meds, or the refrigerator, or the medicine cabinet in the bathroom. Usually those are the three places. I've found things from 20 years ago, long expired. And with the patient and family permission, I will get rid of lots of stuff. And I'm like, what are you doing with this? And they're just saving it just in case. But it's been expired for 20 years. Some of them can actually be harmful. It could be poisonous now, whereas it was useful before. So I'm sure some of my patients would say that I'm too nosy, but I do it with good intentions anyway. I don't know if any of you have seen this. This is a mediset. There are various versions of this, but this one is the one I really like. It has the days of the week on the top, and then 4 columns. There's a breakfast, lunch, dinner, bedtime. So for somebody who's confused a little bit, or who has slight memory problems, maybe a friend or a neighbor or a daughter or son could come in once a week and fill this. But remember, you have to know the day of the week and the time, right? If you're that disoriented, then this is no use. You need more supervision. But for some who they're oriented but just need a little bit of help, this can be very useful. So in summary then, successful prescribing means the right drug at the right dose for the right condition and the right patient, and taking into effect individual preferences as well, and their goals of care, which is very important to us in geriatrics. So I'll end with this. The other day I heard a couple of doctors in the hospital talking, and the first one said, what exactly does a geriatrics consultant do? And the other guy said, not too much. They just stop half the medications and they cut the doses of the rest. So the first one said, anybody can do that. And the second one said, the trick is figuring out which half. So on that note, I'll end, and I'll see if you have any questions.